You're listening to Medscape's In Discussion series on Idiopathic Pulmonary Fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, Professor of Medicine in the Interstitial Lung Disease Program at National Jewish Health in Denver, Colorado. Dr. Swigris directs research centered on how patients live with and experience interstitial lung diseases, how to best assess that experience, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Welcome to Medscape in Discussion on the topic of idiopathic pulmonary fibrosis, or IPF. I'm Dr. Jeff Swigris, and today, in our final first season episode, we'll be discussing what the future of IPF medical care will look like in terms of prevention, earlier detection, delayed disease progression, and the diagnostic tests and therapies that will make it all possible. To get a closer look at these future possibilities, we've invited a person whose really impressive portfolio of clinical and translational research includes, among other things, studies of novel compounds for IPF and other interstitial lung diseases. He is director of the Interstitial Lung Disease Program at the University of Southern California in Los Angeles and professor of interstitial lung disease at Imperial College in London. Toby Maher, welcome, and thank you for making the time for this conversation.
Jeff, thank you. Always a pleasure to be catching up, especially when other people can listen.
Great. Toby, let's talk first about how you became interested in the field of interstitial lung disease. What was the initial thing that piqued your interest about this field?
Yeah, and it's been a while now. So 20 years ago, in fact, more than 20 years ago, I started working at the Royal Brompton Hospital in London as a resident in American terms. And about 2 weeks before I was due to start, I was phoned up by the director of the program. We told he was changing the job that I was going to be doing at the Brompton. I wanted to do the sleep and ventilation job so that I could learn more about, how to use ventilators properly. But instead, I ended up being assigned to work with Ron Dubois, doing the ILD job as his resident. And 6 months later, I guess it was Ron's fault. It convinced me that ILD was the most fascinating problem in respiratory medicine. And I think that's true. ILD has the beauty of imaging. We can look at CT scans. There's a lot of complexity. And even now, 21 years later, there's a lot of unknowns. So from a research perspective, there were a lot of questions to try and answer. So it captured my interest, and here we are a long time later, and I'm still enjoying it.
Yeah. And what a great first mentor, Ron Dubois, for the audience, if you don't know, a gentleman and a scholar, and just really one of the pioneers in the field of interstitial lung disease. And Toby's so lucky to have that influence. And as you know, we were lucky enough to have Ron here for a while as well here in Denver at National Jewish. Well, let's move on now to the topic at hand. And let's talk first about early detection. And just speak to us, if you would, about why you think it's so important for us to make a diagnosis of fibrosing interstitial lung disease early. One, why is it important? And two, how do we do it?
Yeah, the first question is a little bit easier than the second part. So why is it important? Well, fibrotic lung disease is a disease that travels in one direction only. Once patients have developed fibrosis, they have irreversibly lost functioning lung. And as it stands, none of the therapies available to us will reverse that fibrosis or will reverse that physiological loss. And so the earlier we can identify our patients, the earlier we can think about starting treatment, and the better our chances of preserving what normal lung tissue they still have. So I think early diagnosis is really crucial from that perspective. The how do we do it is the harder part. I think since we've had treatments for the last decade, we've spent a lot of time raising awareness about the diagnosis of fibrotic interstitial lung disease, both among our other pulmonology colleagues, but also in primary care and with cardiology and radiologists, so that we try and get these referrals as early as possible. I think for all of us, having a high index of suspicion and really getting to doing the CT scan as early as possible are all keys to trying to make the diagnosis. And then obviously, once that patient has come to see an ILD expert, I think there are still issues around streamlining the diagnosis. You've been involved in a lot of the discussions about classification. And I do think one of the challenges we have within ILD is that diagnosis and giving patients a label can still be difficult, even when they're coming to centers like yours and mine. I do think this development of the concept of progressive pulmonary fibrosis has helped us to a certain extent. If we're at a loss to give the patient a precise label, whether it's IPF or NSIP or hypersensitivity pneumonitis, we at least now know that if they've got fibrosis that's getting worse, we can still come up with treatment options for them.
Right. And I think that term, progressive pulmonary fibrosis, reminds people, practitioners, exactly what you said, that generally pulmonary fibrosis moves in one direction. And, how that happens and the variability in the course of the disease, of course, is tough to figure out. But in general, the fear is that fibrosis worsens, and as you also mentioned, physiological decline, irreversible loss of lung function. And I think that brings us into the next question really nicely, and I'm sure you get asked this quite a bit, and it's an almost impossible question to answer, but what do you say? Because patients ask us this. What do you say to a patient who's newly diagnosed with IPF, and they say, Dr. Maher, how long am I going to live? You told me this is a bad disease. Fibrosis progresses in general. How long do you think I have?
Yeah, so always a challenging question. And one is treading a tightrope between not wanting to terrify the individual nor to sort of strip them of hope. And I also think we have to acknowledge that as doctors, we're not very good at giving precise estimates for the individual. We're pretty good at population-based estimates. So I always explain to patients that if I have 100 patients like them, then without treatment in 3 years' time, half of those people will be dead. I have no way of predicting which half they will fall into. And then my take on the current treatment is that it probably does extend life expectancy by as much as 18 months to 2 years. So I communicate to patients that a lot of the information that's on the internet is now out of date because we haven't really seen it catch up with the improvements in life expectancy with therapy. So I try and balance a realistic impression of how the disease behaves and why it's important to treat it, whilst at the same time trying to maintain the hope for the patient that actually their disease will be treatment responsive, for want of a better term, and that actually their prognosis might not be as bad as they will have feared having read about IPF on the internet.
So true. That seems like half of those patients who have been on the internet and are absolutely terrified, and their interpretation of, as you mentioned, these at times outdated information is, oh, I'm dead in 2 years. I have no hope, I'm dead. And then other patients who come in and are just absolutely uninformed and have no idea, or have been told maybe by another practitioner, oh, it's a little fibrosis, don't worry, you're going to live with this for another 30 years or something like that. And so, yeah, our job is to strike that balance, to be realistic, but not take away hope. And we've been lucky enough to live through seeing successful therapies. So many docs before us tried and never saw success in their therapies. Can you talk to us about just the general direction you think the field is heading in terms of what therapies are emerging and what those therapies might have in store for the treatment of our patients with pulmonary fibrosis?
Yeah, so I think from a trial perspective, it's been an exciting time recently. At the ATS, we saw the announcement of data from BMS with their LPA receptor 1 antagonist showing positive data at 6 months. We also saw Pliant's alpha V beta 6 integrin inhibitor, again with positive data at 3 months. The year before, we saw the data on Boehringer's PDE4 inhibitor. Before that, there was the data on treprostinil, originally in their sort of PH-ILD study, but which interestingly seemed to show an effective drug on FVC change. So we have a whole series of drugs that look to be entering phase 3. And, if you look at the industry success rate at phase 3, it's about 50 to 80% success across all diseases at phase 3. But one would hope that with 4 good shots on target, we will see at least one of those, if not 2, successfully reach approval. And I think it was transformative to have the first 2 drugs, pirfenidone and nintedanib, approved in 2014. Hopefully, if we can get 1 or 2 of these new drugs, I think that's going to be another step change into the future for what we can offer our patients in terms of therapy.
And do you think that step change is going to be additive? Meaning, okay, if 1 or more of these drugs that you mentioned that are entering or have entered phase 3, if they're successful, are we adding those to nintedanib and pirfenidone, or are those going to be standalone therapies? And what would that look like in terms of effectiveness if it's combination therapy?
The short answer is that I expect combination therapy to be the standard for the majority of patients. If we look at the current situation, there are a proportion of patients, maybe a fifth of our patients, who do seem to see true long-term stability on the current available therapies, but the majority, the 80%, continue to progress and deteriorate. But obviously, based on the trial evidence, our expectation is that progression is slower than it would have been without therapy. And so I think for those patients who are continuing to deteriorate despite treatment, my suspicion is that combination therapy is what is going to work best. And certainly, if you look at the phase 2 trial data for all those studies I've mentioned, none of them is arresting disease progression in all patients. And so until we reach that sort of nirvana of having 1 drug that arrests and ideally reverses fibrosis, I think we're going to be looking at combination treatment. And there's precedent in the pulmonary hypertension field where they have multiple drugs that target different mechanisms in the disease pathway, and they've got clear evidence that combining those drugs offers greater efficacy than each one on its own.
When we talk about combinations, or we talk about any mode of delivery, does one seem better to you than another in terms of oral versus inhaled versus IV? When you think about what we know about the pathophysiology of lung fibrosis, does any one of those strike you as being potentially more effective, or the possibility of being more effective?
For ease of use, I think a daily tablet is probably the optimum choice. But obviously, as pulmonologists, we're very used to administering inhaled therapy to our patients, albeit the ones with asthma and COPD. I think as pulmonologists, we're comfortable with inhaled treatment, and the virtue of inhaled treatment is that you can potentially get drug at much higher concentration to the lung with less systemic absorption, which in turn will cause fewer side effects. So there is a lot of attraction to using the inhaled route if we can find the right drug with the right physiochemical characteristics. I think potentially the ideal combination is once daily tablets and, if necessary, a once daily inhaled therapy. With intravenous treatments, they're obviously less convenient for our patients if they have to come up to the healthcare facility every 3 or 4 weeks. Subcutaneous, I think, is certainly a halfway house. And again, with asthma, we've seen the success of a lot of subcutaneous treatment. So we know that it's certainly feasible in patients with pulmonary disease, and one would imagine equally so for our patients with pulmonary fibrosis.
Right. So you mentioned several drugs that are in the pipeline. How can we shorten the time from drug discovery to being able to prescribe these to our patients?
Yeah, that's the $1 million question. There's obviously the developmental pathway that drugs have to follow, the phase 1 through phase 2 through phase 3. And obviously one of the things that can be done to shorten that is finding better clinical trial endpoints that give us a readout at an earlier stage. Now, I think for phase 3, our hands are tied. The FDA have certain expectations that trials are going to be at least 12 months long, and that's not just to demonstrate durable efficacy, it's also to provide reassurance that drugs are safe in longer term use. So I think the phase 3 trial duration we're stuck with, but where we've been trying to make a difference particularly with work around biomarkers, is how we can shorten the phase 2 study. Can we find simple markers, potentially blood measures, and things that we've looked at with success have been sort of CA125 and some of the neoepitopes of collagen turnover. Can we perhaps develop a panel of biomarkers that will tell us within maybe 4 weeks or 12 weeks with a reasonable degree of confidence that we have an effective drug? And if we can sort of shorten and shrink phase 2 trials, then that should help to accelerate studies. I think the other thing that can be done is around delivery, and we've seen huge changes in how, as an ILD community, we've gone about recruiting patients to clinical trials. I think people forget that the first multi-center trial in IPF was really less than 20 years ago with the gamma interferon studies, and they took several years to recruit. More recently, we've seen a rapid acceleration in the recruitment of patients with IPF into phase 3 trials, and I think that's come about because as a community, we recognize the importance of studies. Pulmonary Fibrosis Foundation and others are in communication with patients about studies and telling them where the opportunities are. We've got more trial nurses working in our centers. So all of these things have gone into improving our ability to recruit for trials, which then speeds up the trials themselves. So I think there's several things we can do, and we have been doing to speed up this process.
Great answer, and that brought up a lot of points. And as you mentioned, this first trial, this interferon gamma trial that you and I lived through, I was a fellow at the time, but I'm sure you recall the general sense and the dogma in our field was you will never enroll a large phase 3 trial, right? 300 patients, you're never going to be able to do that. And now a trial here recently is 5 months ahead of schedule, enrolling several hundred patients from around the world. So it's just incredible progress in terms of numbers, getting patients into trials. Patients come in and say, why can't I get on this drug? I don't want to go into the trial, get me the drug. And we have to remind patients, well, it may be safe in humans, but we actually don't know that. And we've gotten burned or come to realize that, these drugs are not like multivitamins. They do have potential downsides, and that's why we do the trials.
I think that's an important point. It's very easy to imagine that being on a new drug is a positive thing, and yet there are examples of trials that we run in IPF and other diseases where it was actually better to be on the placebo because some of these drugs caused harm. So I fully agree. We have to balance our thinking about these new drugs, and it's critically important that we do these placebo-controlled studies, both to prove that a drug is successful, but also to prove that drugs aren't dangerous or potentially harmful to our patients.
Last question. When you think pie in the sky, but reversing fibrosis is not an option, but you think about the current landscape, the number of different pathways that could be targeted, the potential genetic information we can get from patients, the biomarkers, how would you see putting all of that together and sort of packaging that up to figure out the best approach to therapy for an individual patient? How is that going to happen? When is that going to happen?
Yeah, so I think to sort of challenge what you said at the start of the question that fibrosis isn't reversible, I think it comes down probably to when we identify fibrosis as to whether it's reversible or not. So when we see a patient in our clinic who's now got an FVC of 60% predicted and a DLCO of 35% predicted, and they've got lots of honeycomb change, I agree that's going to be entirely irreversible. The lung has been destroyed. We're just not going to be able to get rid of the fibrosis and restore normal lung architecture. But if we capture that patient 3 years earlier, when they've got subtle subpleural reticulation, they've got minimal disease and well-preserved physiology and lung structure, maybe that sort of disease will be reversible. And so I think there's a number of tools becoming available that will hopefully help us identify those patients at risk of fibrosis. We already recognize from the lung cancer screening programs that there's this subset of patients with interstitial lung abnormalities, which in many cases seem to be the precursor to them developing clinically overt IPF a few years down the line. And if we can use genetic risk scores, if we could hopefully use simple blood biomarkers, if we could have the PSA equivalent for lung fibrosis so that we could add the lung to screening programs. Once we hit the age of 40 and onwards, we're encouraged to go and see our primary care physician to be screened for prostate cancer, and women get screened for breast cancer and cervical cancer. And there's an opportunity there if we develop the right tools to be able to screen for pulmonary fibrosis. Because the real ideal would either be to undertake primary or secondary prevention to stop these patients coming to our clinic with breathlessness and incipient respiratory failure, but instead intercept the disease early on when we might genuinely reverse it and truly change outcomes and prevent mortality. So I think we're at an exciting pivot point where we're beginning to develop the tools to both identify those patients and hopefully then to intervene and prevent the development of IPF.
I would throw in there when patients go to visit their primary doc and they're talking about cancer screening and so forth, the practitioner just throws the stethoscope down at the base of the lung and listens for crackles. We know that can be incredibly informative. And if you hear Velcro, get an HRCT. Given all that we've covered in this short time, Toby, give me the one big bullet point that you want the practitioners who are treating people with IPF to consider differently. What do you want to emphasize?
I think we need to keep our patients front and center of this. We need to remember that to make a difference, we need to listen to them, and we need to listen to them early in the disease course. We need to be their advocates, and we need to continue this sort of struggle to develop new medications, new diagnostics, because I ultimately, by the time I get to the end of my career, I would love us to have stopped our patients dying from respiratory failure. It's been great having new treatments, but my patients still sadly die. And I have maybe close to another 20 years to make a difference. And I think as a community, we've achieved a lot in the last decade. If we can do the same decade on decade for the next 20 years, then I think we may be coming close to making a genuine difference and hopefully getting away from this expectation that our patients are ultimately going to die from their IPF.
Wonderfully said. Absolutely. Well, we've come to the end of our time. Toby, thank you very much for being here. And to the audience, thanks for listening to this final conversation of our first season on idiopathic pulmonary fibrosis with our guest today, Dr. Toby Maher. Please be sure to check out the Medscape app for prior episodes and share, save, and subscribe if you enjoyed this episode. I'm Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.